but his lab at discharge was as follows. 4+ glucose in the urine. Oh my gosh, he's got diabetes, we need to do something, right? And you know if I say something with a smile on my face like that, you know I'm full of it, right? Okay, let's look a little more closely. Let's look at blood glucose. It's normal. So maybe this guy's not diabetic. Okay, so normal blood glucose, but spilling out glucose in the urine. How could that possibly be?
Proximal tube problems?
Yeah, it's a proximal tubular problem because we know that glucose is reabsorbed in the proximal tubule, right? Pretty much 100%. And so if the blood glucose is normal, but you've got glucose in the urine, then probably the proximal tubule's not doing what it should. But if we've zeroed in on the proximal tubule. Let's look at, okay, the CO2, which is the bicarbonate. Looks like an acidosis. And that would have fit with diabetes, but we've already decided that that's not diabetes. So, acidosis, maybe he's not getting rid of his acid. That could also be a proximal tubule problem, right? Could be distal. Okay. What about the urine pH? It's alkaline. Usually urine is relatively acidic, and so a urine pH of 8 is unusual. Unless you're eating a very alkaline diet, it tends to be unusual. Most of us generate an acidic urine. So that's also consistent with the idea that he's not getting rid of his acid. So he's got an acidosis due to a kidney problem. And I think, again, we've decided it could be proximal tubule, could be distal. What about the others? Sodium, well, sodium could be a little bit low. What about the potassium? The potassium's low. So one thing that we haven't made clear at this stage is, although we regulate potassium mostly in the distal tubule or distal nephron, there's also a lot that's reabsorbed in the proximal tubule. And so this may be consistent with what? Oh, is there anything else there? Oh, what about the phosphate? Previously, when we had a low GFR, the phosphate was high because we couldn't excrete it. But the phosphate is low. And do we know where phosphate's reabsorbed mostly? Mostly in the proximal tubule. So this is kind of tying in with the idea that we have a proximal tubule error that's not allowing us to reabsorb a lot of substances. And indeed, that's the case in with this particular patient. Has a generalized proximal tubule defect. Yes?
Can I ask a question? Why would you not also see amino acids in the urine?
Oh, actually, the amino acids, there is a problem with amino acids, but I don't think it's listed here. Yeah, this is Fanconi or renal tubular acidosis type 2, and often they need amino acid supplementation. Yes. So I could, next year when I do this case, I could put that in, couldn't I? Yeah, okay, good. Thank you for that suggestion. Oh, anybody that can improve my presentations has to get fat. Okay, so let's flip the page. There's really not much in Costanzo on this, but I wanted to talk about glucose transport. And what I'm going to do here is This is the proximal tubule early, and this is late in the proximal tubule. Okay. In here, this is SGLT2. That's just the name of this transporter. Sodium glucose link transporter. Okay. Down here, you have another glucose transporter. It's slightly different, SGLT1. Okay. Glucose concentration is high here. Facilitated diffusion with a facilitated diffuser called GLUT2, and here GLUT1. Okay. So the process that's going on here is there is secondary active transporter glucose here by a mechanism which tends to be kind of a low affinity, but there's a lot of this guy, and so it moves most of the glucose. By the time you get down to the end of the proximal tubule, of course there's a lot less glucose because you've reabsorbed most of it. And so you need a high affinity transporter, which needs more sodium to make it work, a high affinity transporter to squeeze out the last amount of the last little bit of glucose. And indeed, glucose reabsorption is close to 100%, largely because of this final squeeze. But still, most of it is reabsorbed by the SGLT2. So, why did I make a big deal of this? The reason I made a big deal of this is that we now have drugs which interfere with SGLT2. And the first one was Invokana, but there are a whole bunch of them now. Inhibits that. Okay. So when this first came out, oh boy, did I make a mistake. You know, I thought, oh gosh, the idea is that if you inhibit that pump and pee out lots of glucose, it will reduce hyperglycemia in diabetes. And because you know that most diabetic problems are due to a maintained hyperglycemia, too much glucose, then the logic was that if you could get rid of more glucose, you would prevent all those things from happening. Now, in my mind, I didn't like the idea of using this toxin to achieve an end. But it not only turns out that this has been incredibly effective, but it's also got a lot of other benefits as well. So it has proven to be a very effective drug to treat type 2 diabetes. Okay? So it works. It basically makes you pee out more glucose and reduces the hyperglycemia. What is interesting is it's also got probably a lot of other benefits too. And so it's almost, could be potentially a miracle drug. And I want to go over to here. I'm going to tell you that it's also renoprotective. In other words, if you use this inhibitor in diabetics, it protects the kidney from nephropathy. Okay? So it is worth trying to understand what's going on here. In a diabetic, you have hyperglycemia, and so you have the proximal tubule working harder to reabsorb sodium and glucose. Okay, because you've got more glucose that appears in the proximal tubule. Hyperglycemia, higher filtered amount, and therefore you have to reabsorb more. By the time the tubular fluid gets to the macula densa, because you've reabsorbed so much sodium, there is less sodium delivered to the macula densa, and tubular glomerular feedback tries to increase glomerular filtration. In other words, it's saying, oh my gosh, we didn't get enough tubular fluid, we need to increase filtration. And so it tends to increase the PGC, and indeed, in type 2 diabetics, you will often see an elevated GFR early in the disease. And so this scheme is probably reasonable in diabetes. Of course, eventually there's a danger that the kidneys will become diseased and the GFR will go down. But certainly in the early phase, it's not uncommon to see an elevated GFR. So there are a number of things that you can use to protect. Let's see what. Oh, the first one's just diet and exercise. Okay, so diet and exercise can reduce hyperglycemia, and that will tend to protect most diabetics, yes? Also, I talked about angiotensin-converting enzyme inhibitors that tend to prevent the increase in glomerular filtration rate and the pressure, because they have a preferential effect on the efferent arteriole. But then the SGLT2 inhibitors also affect this system by reducing the hyperglycemia. So good treatment reduces hyperglycemia, seems to reduce kidney disease, but also, just to add to it, it turns out that people with diabetes and heart failure benefit from this drug also. And we don't know all the mechanisms. So, part of it may be its diuretic effect, but it's turned out that these inhibitors are fairly effective in heart failure. Not only that, they're now giving these drugs to people without diabetes and finding that it helps in heart failure. So really, truly, a very interesting drug. Okay. Any questions on? Yes, ma'am.
So if you don't have diabetes, you have to eat more often to keep your blood glucose higher, since you're paying up a lot of it? Would it cause weight loss or something?
I'm sorry, I don't really understand the question. So if you don't have diabetes...
And they put you on this for heart failure.
Oh, and they put you on it for heart failure, yeah. Yes, you will tend to pee out more glucose. In general, what happens is that it causes a diuresis, and that is one possible reason why it alleviates the heart failure condition. But there are other potential reasons too. So the question that followed on from that was,
you have to eat more often,
oh, would you have to eat? Hey, in this society, how many people don't eat enough? Yeah, it's a good question, and I hope that didn't sound too facetious, but I guess if you go crazy, you could become malnourished, but I don't think it's an issue. So. Oh, I got a note here. This is and I read this just recently. This amazed me. People with type 2 diabetes and chronic kidney disease are 5 times more likely to die of cardiovascular disease than reach dialysis. That surprised me. It sounds unusual. Gosh. Just thought that was an interesting fact. Okay, so let's go on to page 3. And what I've done there, and let me make sure I get this. Okay. What I've done here is I've drawn graphs, basically 3 graphs on the same axis. And so here is filtration. The amount of glucose that's filtered. And clearly, filtration is going to be directly, the amount filtered, the filtered load of glucose, is going to be directly related to the glucose concentration in plasma. So it should be a straight line. Okay? So under normal circumstances, let's use a different color. I'll make sure I get to about the right height. Okay. 100% is reabsorbed, right? So the red line is reabsorption, but it has a T max, or transport maximum. In other words, you only have so many of these protein molecules in the membrane that can move glucose. Okay? And so it's saturable. Once these are all working at 100%, you come out on a reabsorption curve that's flat. And the terminology is usually Tmax. So that's reabsorption. Reabsorption. So, different color. So, under normal circumstances, blood glucose is usually under 100. So, under normal circumstances, if 100% is reabsorbed, then the excretion is 0. However, as you reach Tmax, you get a line that now parallels the filtration line. So when glucose starts to spill out in the urine, it's an indicator that you've got high plasma glucose levels. In most of us that are not diabetic, we stay well below this line. We're back here. Even when we eat something, even when we eat a lot of glucose, it doesn't usually go up, it should not go up to 200. Okay? And I think that's what the graph shows here. Threshold's about 200. Okay? So any spillage of glucose in the urine is indicative of diabetes. Or is it? What's the exception? The Fanconi syndrome that we talked about earlier. Is that, oh, you didn't say that?
No, I didn't.
Oh, pregnancy.
Honestly, I don't know.
Don't think so.
I don't know.
Is there any reason why pregnancy would cause glucose spilling in the urine? I mean, you can get a diabetic syndrome in pregnancy, yes.
You said that you don't want to just rely on the fact that they might have diabetes if it's in their urine, because in pregnancy sometimes their plasma levels could still be normal, but I forget the mechanism that causes it.
Okay, and I'm not familiar with it. I mean, certainly there is a diabetes that is associated with pregnancy sometimes, but in terms of, I am not aware of there being high glucose routinely in plasma, or at least glucose spillage in. Does anybody know? Is there anything consistent? I'll try to find out. Okay, but I don't think it's routine. Okay. Where's my? Oh, here it is. So you're looking at me thinking, okay, so But you know, if I put this up, it's probably important. You know, the shelf exam, the board exams, the step exams love this diagram, okay? So understand it. It's also a diagram that might be applicable to a lot of other substances too that are reabsorbed, other saturable phenomena like you know, lactate, like sulfate, like a whole bunch of things. Most processes are saturable like this. Sodium is not, because sodium, gosh, at the concentrations we have sodium does never saturates. I mean, we've got that sodium potassium ATPase that's supercharged. But most substances, phosphate, sulfate, they have this sort of pattern. Now, the inflection points will be at different points, but same sort of pattern. Yes, sir? Are there any cases where the lines themselves might shift or tilt? And I'm not sure I really understand the question.
Like any long-term pathologies, which will change, I guess, your filtration rate, your excretion rate?
Oh, any long-term pathologies? Well, certainly, yeah, I mean, the first one that comes to mind is the Fanconi syndrome. That we just discussed. Okay, can I think of any others? Change it in what way, though?
Just got used to looking at like these superimposed graphs as like finding a steady state type of scenario. So I mean, for national board exams, for example, would it just be the standard graph and you just have to interpret so the x-axis maybe different with the y-axis more like line shifting?
Yeah, I think that the only thing that can change is basically the Tmax. I can't think of anything else that would bend these lines this way or whatever. But definitely, anytime this changes and comes up and down, it will basically, the excretion lines will tend to follow it in a logical fashion. If that didn't answer your question, I'd be happy to talk with you afterwards about it. But I'm not thinking of anything that can disrupt that general pattern. Just shift it down and up. That's the only thing that I can think of. I'm trying to think. No, I think that it would have to be the same pattern, even if you had something like dehydration or something like that. So, okay. Tell you what I'm going to do is I don't want to overrun, so on the next page, I won't put this up on the board, but you need to be able to understand this diagram. So it's page 4. It's a PAH titration curve. Para-aminohippuric acid. We do have hippurates, but para-aminohippuric acid is not an endogenous compound, but it is a substance that's almost 100% secreted. And we're going to use it tomorrow when we discuss clearance. But the point is that the filtered line is still the same. I mean, the amount filtered is directly proportional to the amount of PAH in the plasma. But in addition to what's filtered, you've got secretion on top of it. And of course, you have a Tmax. but this excretion must be the sum of what's filtered plus what's secreted. And so the line shifts over to the left. Do those lines make sense to you?
Why is secretion not the same as absorption?
Why is the secretion not the same as
Absorption, but in the last graph.
absorption? Okay. Okay. So before we were talking about reabsorption. Now we're talking about a very different animal. We're talking about secretion. So with reabsorption, you have filtration and then reabsorption. Here we have filtration, no reabsorption, but then on top of the filtration, more is secreted into the tubule. And so the total amount that we lose, that we get rid of, is the sum of what is filtered plus what is secreted. Okay? And if that's still a problem, I'd be happy to talk with you afterwards about it. Okay? But look through it, see if you can figure it out, and if it's still unclear, I'd be happy to talk to you about it, okay? Good. And I will make the observation that it is now 20 to 12, and this thing doesn't work as easily at 20 to 12, does it? I have to work to keep mine in check too. Okay, so having said that, I need you to put your thinking caps on again, and I need you to be sharp, and I need you to be able to think straight, and I'll try to do my best to keep up with you. Okay, so what we're going to talk about now is a concept, first of all, of glomerular tubular balance. And I'll try to reproduce that diagram pretty much exactly. It's a hard concept to test, but I do have at least one question in the exam on this. See, that's my sneaky trick of trying to get you to pay attention. Okay, so let me draw this and I couldn't get, Costanzo doesn't have a diagram, so I picked this one up. So here's the glomerulus. Here's the efferent arteriole, and this is the peritubular capillary. And okay, so this is a little different. This is the nephron and this is the blood vessels. Okay, it's not a standard shape, but that's about the best I could find. So what we're trying to do here is I'm trying to convince you that if there's a blip in the GFR, in other words, for whatever reason, you know, we move around, we jingle or whatever, and there's a sudden blip in GFR, then we can adjust the reabsorption to